With that, I think let's begin the session. For the first session that we have, the topic is classification of endometrial carcinoma. It will be presented by a resident pathologist from Rajiv Gandhi Hospital. I would like to also invite Dr. Anila Sharma. Dr. Anila Sharma is a senior pathologist at Rajiv Gandhi, and Dr. Neha Bakshi. They are from Gangaram Hospital. They are going to mentor this talk. And I invite Dr. Sen Gupta. She's a DNP resident in pathology at Rajiv Gandhi to present on the classification of endometrial cancers. She's going to talk of new perspectives beyond morphology. So, Dr. Sen Gupta, you may kindly proceed.
Am I audible?
Yes, you are.
Yeah. Good evening, everyone. So first, I'll share my screen. Yeah. So to begin. Okay. Good evening. So the topic for today is the molecular classification of endometrial cancer. So now endometrial cancer, to introduce, it is the most common invasive cancer of the female genital tract worldwide. In India, it ranks third after carcinoma cervix and carcinoma ovary. According to the Global Cancer Stats of 2018, it accounts for 0.9% of all cancer deaths worldwide. The goal, what is the need for classification of endometrial cancers? The goal is to predict the patient prognosis and guiding the management. It has evolved, of course, it has evolved over time. Initially, the first classification was that of anatomical classification, followed by the clinico-pathological classification, then the morphological classification given by WHO, and the latest is the molecular classification, which has been given by the Cancer Genome Atlas. And so in the first classification, it was obviously, initially it was classified based only on anatomical location, that of the uterine corpus and the cervical. Then came the Bokman classification, where there were two pathogenic types were described, type 1 and type 2. 80% of all endometrial cancers, and endometrioid type of endometrial carcinoma, the mucinous carcinoma fall under type 1, while the serous, clear cell, and the mixed carcinoma fall under type 2 endometrial carcinomas. Now, in case of type 1, unopposed estrogen, hypertension, diabetes, obesity, these are all the risk factors, while atrophic endometrium and women of thin stature, they are risk factors in case of type 2 endometrial carcinomas. Hyperplasia, endometrial in situ lesions, that is the precursor in type 1, while serous endometrial intraepithelial carcinomas are the precursor in type 2. Type 1 cancers, they are slow growing, while type 2 endometrial carcinoma, they show a rapid progression. And both the groups are associated with a particular set of mutated genes or the genetic abnormalities. In type 1, they are P10, ARAD1A, PIK3CA, KRAS, FGF2, MSI, POL, TP53, while in case of type 2, TP53 aneuploidy, PIK3CA, CCNE, and PP2A, these are the genetic mutations which are associated with type 2. Now, in 2013, after we have seen this classification, in 2013, the Cancer Genome Atlas, they did a groundbreaking work on approach to the endometrial carcinoma, and they incorporated molecular features into the molecular features and came up with the latest classification, about which I'll be talking in detail. So in this, it has been classified into 4 entities. That is the pole ultra-mutated endometrioid carcinoma, there's mismatch repair deficient endometrioid carcinoma, P53 mutant, and no specific molecular profile endometrioid carcinomas. So now coming to the histomorphology, endometrial carcinomas on microscopy, we see a varied array of patterns. They can have a secretory pattern, a non-villous, papillary, villoglandular, microglandular, sex cord-like, and mucinous. All these patterns have been described in endometrial carcinomas. Now, based on the histomorphology, FICO has graded endometrial carcinoma into 3 grades, of which we all know. And based on the percentage of tumor, which is composed of non-squamous solid masses, it has been put into the 3 grades. Now, coming to the current risk stratification of endometrial carcinoma. It is a surgically staged disease, and the risk stratification model, it incorporates the key pathological parameters of histotype, grade, and stage. The major challenge in this stratification is distinguishing between the low, intermediate, high risk stratification, and management decision is based on this risk stratification. High risk features have a higher likelihood of recurrence, and adjuvant treatment are recommended in these cases. So now coming to the ESMO risk stratification, which are the latest revised ESMO risk stratification. So low risk cancers are those which are stage 1A with endometrioid type, and there is no or very focal lymphovascular invasion is described, and also stage 1 or stage 2 pole mutated cancers. The intermediate risk ones are stage 1A G3 with endometrioid type, stage 1A non-endometrioid types, and also P53 mutated cancers without myometrial invasion and no or focal lymphovascular invasion. The third one which is included in this is the stage 1B with endometrioid type with no or focal lymphovascular invasion. And the fourth is the stage 2 G1 endometrioid cancers with no lymphovascular invasion. Next comes the high intermediate risk. High intermediate risk in this, the cancers which are included are the stage 1 endometrioid, which are of any grade or any depth of invasion with substantial lymphovascular invasion. Stage 1B with endometrioid type, and in this the presence or absence of lymphovascular invasion doesn't matter. Stage 2 G1 endometrioid cancers with substantial lymphovascular invasion, and stage 2 G2 or G3 endometrioid cancers. These are the ones which form the high intermediate risk. Then comes the high risk. High risk is all stages and all histology with P53 abnormal and myometrial invasion. All stages with serous or undifferentiated carcinomas, including carcinosarcoma with myometrial invasions, and all stage 3 and 4A with no residual tumor, regardless of histology and regardless of molecular subtype. Now, coming to the part of our pathologists, we all take the aid of IHC in typing, and it is all the most beneficial way is to always use a panel, and it has to be the interpretation and application of IHC always has to be done in conjunction with morphology, and that helps in the helps us to reach a overall diagnosis. So coming to ER, estrogen receptor, classically we see in a low-grade endometrioid carcinoma, diffuse ER positivity is present. However, in serous carcinoma, many show ER negativity. In P53 mutation in serous carcinoma, aberrant P53 staining, that is all or none, is followed. So if it is positive, it is positive or significant if there is more than 75 cells showing diffuse nuclear positivity, and otherwise it is null or complete absence. That happens in case of nonsense mutation resulted in truncated protein. And in problematic cases, if P53 is not, if it's not aberrant, then it's not serous carcinoma. Now, P16 in case of serous carcinoma, it shows diffuse positivity. And in case of endometrial carcinoma, it shows a mosaic pattern of positivity, P16. Now, so what is the need for this molecular classification? Patients with histologically similar endometrial carcinomas, they have very different outcomes, notably in patients who have high-grade endometrial carcinomas. So in that case, the need for molecular classification is very important based on the prognostication and also the further management of the cases. So as I already said, that the Cancer Genome Atlas has described the 4 groups, and based on the integrated genomic architecture, it has rather than a single genetic mutation, and this subclassification has direct clinical, prognostic, and therapeutic implications. So it was a landmark study in many ways, and it provides a new framework from which to approach endometrial carcinoma. It is based primarily on somatic copy number alterations and the tumor mutation burden. 4 distinct classes have been described. So what are the 4 groups? The first is the ultra-mutated endometrial carcinoma with DNA polymerase epsilon mutation in the exonuclease domain. The second is the hypermutated endometrial carcinoma with microsatellite instability. Third is low mutation rate endometrial carcinoma with high frequency of DNA copy number alterations and TP53 mutations. And fourth is the low mutation rate with low frequency of DNA copy number alterations. Now coming to the prevalence of the 4 groups, pole mutated cancers have shown 12% prevalence, while the most common is the MMRD, that is 40%, and no specific mutational profile shows 30% prevalence, while P53 shows 18% of prevalence. So the pole exonuclease domain, the pathologic pole variants of the exonuclease domain of the pole gene, they comprise approximately 10% of endometrial carcinoma, and in a majority consists of one of these 5 hotspots. In our institute, we are doing pole through Sanger sequencing, and the primers we have made, they include this 286 hotspots, 286, 411 and 424. So these tumors, they have very high somatic mutational frequencies, and they are copy number stable, but ultra mutated endometrial carcinomas with recurrent mutations. As I already said, the prevalence is 12%. And in this case, what happens is that the mutation in the exonuclease domain of DNA polymerase epsilon is responsible for proofreading function. So mutation in this domain leads to replication errors. And there is high, this somatic mutation frequency is very high. Now, on histomorphology, what do we see in these cancers which turn out to be pole mutated? So they are associated with broad front tumor invasion pattern. Tumor giant cells are present, and we see a prominent TILs are also very prominent in this histomorphology of pole mutated cancers. Now, this analysis of sub-analysis of pole mutated and pole wild-type endometrial cancers was done in the PORTEC-1 trial. And when these 2 groups were compared, the 10-year recurrence-free survival was 100% in case of pole mutated, as compared to 80% in case of pole wild-type endometrial carcinoma. So this finding suggests that the pole mutated endometrial carcinomas, they possess intrinsic characteristics that are beneficial for survival, independent of sensitivity to adjuvant treatment. Therefore, treatment de-escalation has towards there is no additional treatment for patients with pole mutated endometrial carcinomas has been proposed, which is a great benefit in these cases. Now, what are the diagnostic tests to identify this pole mutated endometrial carcinoma? whole genome and exome sequencing. These are the two methods proposed by the TCGA, but recommended is Sanger sequencing. So we are in our institute, we are doing through Sanger sequencing, panel-based NGS, incorporating the pole exons 9 to 14. This restrict the pole designation to tumors associated with the pathogenic pole variants. Okay, and they demonstrate a high mutational frequency and increased proportion of C to A transversions and pole mutation at a residue that is recurrently mutated in cancer. So these cancers, they are susceptible to immune checkpoint inhibition, and excellent outcomes for this patient may not necessitate this expensive therapeutic option, because as I already said that treatment de-escalation has been proposed because of the inherent nature of this tumors to show for a better prognosis. Now, why do they have a better prognosis? Better prognosis because the tumor neopeptides caused by alpha mutation, they stimulate a cytolytic immune response, which is analogous to previous observations in hypermutated MMRD colorectal carcinomas. Also, as I already said, that there is a higher density of tumor-associated lymphocytes more than the other endometrial carcinomas. So CD8 cytotoxic T cell infiltrate is it is capable of cytolytic activity, and this is evidenced by co-staining for the activation marker TIA1. So these patients, they are optimal candidates to respond to anti-PD-L1 treatment. Now coming to the second one, that is the hypermutated endometrial carcinomas with MSI instability. Dysfunctional mismatch repair proteins, that is the MLH1, PMS2, MSH2, and MSH6. In majority of them, epigenetic silencing of MLH1 has been seen, and in minority, the MMR deficiency is caused by somatic or germline mutations in the MMR genes. That is the Lynch syndrome, but that is a very small percentage of these cases. And this leads to high mutational frequencies, that is around more than 10 mutations per megabase. And prevalence is 40%. Often they are associated with high-grade endometrioid carcinoma. And as I said, it is associated with sporadic epigenetic silencing. And the diagnostic tests which are preferred is the MMR-IHC, MSI assay by next generation sequencing. So in these, we see a advanced MELF pattern of invasion can be seen. That is, there are microcystic glands which are lined by flattened eosinophilic epithelium with luminal inflammatory cells, and they're surrounding the myxoid stroma. These glands, they show fragmentation, clustering, and individual neoplastic cells are admixed with a rich inflammatory cell population in the stroma. So what are the diagnostic tests to identify MMR deficient and MSI high endometrial carcinomas? Two methods, that is the MSI assay and IHC for MMR protein. MMR IHC has of course become the most preferred test in all pathology laboratories, and testing, so yeah, that is the thing. Then coming to the third category, which is the somatic copy number alteration or carcinomas. So they are similar to the high-grade serous ovarian carcinoma. They are associated with frequent TP53 mutation in almost 92% cases. They are high-grade endometrial carcinomas, and they are associated with lymphovascular invasion, destructive growth patterns, glandular and solid forms. There is they are associated with giant tumor cells, hobnailing, and they generally they present at the advanced stage. Therefore, they have a poor prognosis, and they have high somatic copy number alterations. Diagnostic tests preferred is the P53 IHC, and targeted therapy can be given that with the PARP inhibitors. So the diagnostic tests to identify this category, this obviously P53 IHC is the preferred one. And now they have two types of mutation. One is the gain of P53 function, and the other is the loss of P53 function. Now, coming to the P53 IHC, 4 patterns have been described. Now, first is the mutant overexpression. The second is the mutant null mutant type. The third is the cytoplasmic type, and the fourth is the subclonal abnormal P53 expression. So a mutant overexpression, which is the most common pattern, in this, the majority, that is 80 to 100% of tumor cells, they show strong nuclear expression of P53. And it is most often associated with missense mutations in the DNA binding domain of TP53. Now, coming to the null pattern, in this, we see there is a complete absence of P53 expression, which is frequently because of frame shift or nonsense mutation. In the cytoplasmic pattern, overexpression of P53 in the cytoplasm of the tumor cells is caused by mutation in the C-terminal domain of TP53. And recently, another fourth type of P53 expression has been described, which is the subclonal type, in which we see that there is a well-defined area within the tumor which shows this overexpression of TP53, while the rest of the tumor, they show a wild-type P53 expression. Thus, in these tumors, though in mostly P53 results they corroborate with the NGS results, but in cases in tumors which are showing a subclonal expression of P53, they might not always, the IHC finding might not always identify with the NGS results, because only a small subclonal population of the tumor cells are showing this this expression. Yes, ma'am.
Yeah, you'll have to speed up. You've already crossed the time allotted to you.
Okay. Okay, ma'am.
So whatever can be, only the pertinent points, please.
Okay. Okay, ma'am. So now the clinical significance of P53, it significantly impacts a patient's individual risk assessment and subsequent treatment. And now coming to the no specific molecular profile, that is also known as the no surrogate marker profile. This is it's a genomically relatively stable MMR proficient subgroup, and in this the tumor mutation burden is moderate, mostly within the PI3K, AKT and WNT signaling pathways. So I'll just skip this, and in this cases the target therapy is done with hormonal therapy, mTOR inhibitors. So this is a table which is just summarizing the entire thing. And so how do we go to the diagnostic classification? The endometrial cancers are first subjected to pole status testing, and the ones which are pole wild type, then the next step is MMR status is found out. And after the MMR deficient tumors have been classified, next we go to the P53 status, based on which no special molecular profile and P53 mutated are categorized. Now, what is the impact of this integrated molecular classification? It has fourfold impact on the pre-op setting, on adjuvant treatment, on surveillance, and in recurrent disease. So on the adjuvant treatment, based on the randomized PORTIC 4A trial, they will compare the standard adjuvant treatment given in this high to intermediate risk endometrial cancer patients with differential adjuvant treatments based on an integrated molecular profile. Currently, the optimal adjuvant treatment in high-risk cases is largely unknown, and more studies need to be conducted in this regard. On surveillance, tailored surveillance adjusted to the patient's risk of recurrence would enhance the patient care, and follow-up is more important in case of P53 aberrant cases than unless in the pole mutant cases. And so what is the impact of recurrent disease? In this case, like in heavily pre-treated MMRD and pole mutant cancers, patients, the progressive metastatic disease is being treated with nivolumab or pembrolizumab. It is pembrolizumab has been approved by the FDA in these cases. Now, coming to the so after this, now there are certain when we classify them in the molecular profile, many tumors are there which will show two molecular profiles. So they are known as the multiple classifier. More than one molecular classifying feature is present in these. And the important thing to know, and these are the combinations in which the molecular profile can present in multiple classifier endometrial carcinoma. The important thing to know is that in a combination of these two cancers, molecular profile, there will be one which is the pole mutated type, and the MMRD, which are the driver mutations, and along with which
Aruparna, we'll stop your presentation. Me and Dr. Neha will just discuss the pertinent points, because I think Neha, you are there?
Yes, ma'am, I'm here.
Yeah, so we'll just summarize what
I'll
Aruparna
stop
is trying
sharing.
to tell. Yeah, no, that's okay, because see, the entire program will have to be, postponed once we go ahead. So basically, whenever we receive an endometrial biopsy, so ideally, we should first do a pole mutation and then do the other IHCs. But in India, we don't do that, because, we are so, we are so used to doing IHC first and pole later. And every institute doesn't have the facility of doing pole mutation. So, but in normal, according to these classification, you have to do pole. And if you cannot characterize the tumor by pole mutation, then you go ahead and do your P53s and the other IHCs. But otherwise, when we get an endometrial biopsy, be it any type, we do one ER, L1 CAM, P53, P16 to rule out serous, whether it is serous, and MSI in most of our cases for all the endometrial cancers. If it is not endometrioid and supposingly it is serous, then you do HER2 first and not MSI. So this is for the students that as Aruparna has told us in details that what happens, the prognosis, etc. is there. Now, Neha, would you like to add on something? Then I'll tell other things, whatever is left.
Yes, ma'am. So, like you said, ideally one should start with pole, but in our setup, obviously we are doing IHC. But it's important that when we are doing IHC, then one has to do all the IHC. So, not just an MSI, MMR IHC or just a P53. So basically do all, and always remember the importance of basic ER. So ER also has importance in these tumors, especially when we reach that NSMP group. Their ER positivity, negativity has important prognostic value. So that also we should remember. And further, ma'am, I think you can.
Yeah. So one thing is, which is very important now, is that sometimes what will happen is that you will have either a subclonal P53 overexpression aberrant, or sometimes subclonal loss for the MMR IHC. Now, these have not been incorporated in CAP protocols clearly, but now there is, they want us to report. So we have started reporting whenever we have P53 subclonal positivity, or we have what happens in MMR IHC, even if you see one tumor cell which is positive, you kind of report it as, intact MMR IHC. But now the trend is shifting, that if there is at least 10% of the tumor cells which are showing loss, then you start reporting it, because then otherwise we are missing out on lot of Lynch cases. So we have started to incorporate this in our reportings now. Other thing is that what happens is your P53 is very strong in one area, and other areas you are saying a mosaic pattern, or what we call a non-mutant pattern. So that P53, if you're seeing like this, you either get an MSI done on MMR IHC, so, or a pole mutation. What happens is, whenever a tumor which shows instability or IHC, they will always show a subclonal P53. So we are doing this as a routine now, just to recognize why the P53, because P53 mutation can be seen in pole mutated tumors as well as in the MSI unstable tumors. So that is one explanation for P53. And multiple classifiers, what Aruparna was telling in the end, that whatever it is, P53, if a tumor supposing has a pole mutation as well as P53. Now, whether you take it as good prognosis or poor, because P53 is poor prognosis, whereas pole is better prognosis. So the dominant thing would be pole. So that is how the tumor should be treated. Though, we think that if P53 is there, so it should be treated like a P53 positive tumor. But if you have a pole mutation, that takes the upper hand over any other stain or report. Similarly, if you have a MMR IHC mutant tumor, then it will have an upper hand over P53. That is how, the treatment protocol should be decided. I think this is all. And otherwise, Aruparna has really given a very lucid talk, and she can share the PPT with the interested residents. And Dr. Vinita, Dr. Swarupa, you want to add or ask anything?
Yeah, that was very nice, Dr. Anila. I think I am fortunate enough to go through with your discussing this every time with you. But one thing I think everybody would like to know, that you use different terms for like I always ask you null P53.
And that is a confusion. I want to explain that.
So,
yeah, exactly. See, the thing is, even initially we were also confused, and our reports also many times were reporting like that. So I think, Aruparna, can you meantime show the slide of P53 where you have written that, see, either you write it as P53 mutant or aberrant and P53 non-mutant. Writing P53 positive and negative is very wrong. We have also done it in our initial, when we were taking the baby steps in FGT reporting. So once it is for all the clinicians and the radiation oncologists. If your pathologist is writing P53 positive or at least positive or negative, you have to ask them. Positive, because staining coming positive doesn't mean it is mutation. So like how this slide reads, mutant, it means overexpression, and otherwise you write non-mutant P53. You should not report it as positive and negative. And subclonal, we should have another class sometime about subclonal P53, subclonal MSI, and null type P16. That is entirely, they are in topics in themselves.
And
so
Anila, I think when you said null mutant, many of the publications are talking about it as WT, right? Wild type.
No. See, the thing is, no, that is not right. So null means that we do not say any staining in any of the tumor cells. So that is what is the thing. It should not be wild type. It should not be interpreted as wild type. And null type P53 usually mostly is seen in serous carcinomas of the endometrium. Usually endometrioid does not show null type. I mean, we have never seen in a practice, though they write, it can be seen. So null type P53 also means it is mutant. So I think pathologist should always write mutant P53, whatever, null type or overexpression type, and not positive and negative. So that is the thing. But we have also rectified our reports now, and this does cause confusion. And anything else, Dr. Swarupa?
I think, next we can discuss in the panel discussion also.
Ma'am, can I put one quick question to Anila, ma'am?
Yeah.
Yeah, ma'am, I just want to check with you regarding this subclonal pattern of P53 that we are reporting. So do you report it that in any small focus, or are you following that 10% that some of the publications talk about? That
No,
it has
10%.
10%. Okay.
And recently I had a case which was showing subclonal. I think it was 8 to 10%. I did my MMR IHC. It showed loss of MLH1 PMS2. So it always happens. P53 I've seen whenever it is subclonal, it is either associated with pole. So what we do, we write that P53 subclonal population is seen. Go ahead with the MMR IHC or pole mutation or both. Because it kind of, tells us that it is, we should have done a poll. Actually, in our practice also, we are also not able to inculcate. Actually, I should be doing poll first and then IHC later. But we are so used to doing IHC. After IHC, I tell them to do poll. though we have facility to do pole, and pole is not very expensive to do. It's just costs around 8,000. So I mean, we can do pole first and do, but we are ingrained that we have to do IHCF for everything, then go to molecular, no? So that
our institute also, we are right now not doing pole in every case. We are sort of, it's like a case based. We are doing IHC initially in every case, and then sort of doing.
Yeah, but I think we are wasting resources basically,
Yes,
because a lot of them are going to be pole mutated, and we are just doing IHC and then.
Ma'am, I have a quick question, ma'am.
Yeah.
Ma'am, the 40% of, hi ma'am,
Hmm.
40% of our patients are MMR deficient, isn't it? ma'am?
Huh.
When do we suspect Lynch syndrome? When do we have to send the
No,
patient
actually,
for Lynch syndrome?
see, I don't know this, we have done 2 studies. The percentage is, in one it was 23% and 30% in the other case. Actually, Lynch, you have to have that genomic profiling done for the patient on the blood sample, and this thing, and you have to do that genetic counseling, Dr. David.
Yes, ma'am. Yes, ma'am.
See, basically, we are doing more of this thing, MSI, because in a way, sometimes it can change the treatment protocol, like pembrolizumab you can give in MS, these tumors. But as far as the genetic counseling and, taking blood samples and doing, that is how, because still in India, the stress is not so much on, that diagnosing the syndrome. We are more still inclined that whether something's going to help the treatment or therapeutic protocol. Am I right?
Yes, ma'am. Correct, ma'am.
So,
Ma'am, one last question, ma'am, regarding LVI.
Shall we go ahead,
Whether-
David? Shall we go ahead with the
Yes,
rest
ma'am.
of
Yeah.
it?
Yeah.
I think you can put the question in the question
yeah, we'll answer
in the chat.
Yeah.
Yes,
Yeah.
ma'am. Yeah.
There are a few questions for you, Dr. Anila, and Dr. Neha.
Yeah, I'll just.
So I think I'm sorry to interrupt this,
No, that's
but
okay.
we have to go ahead. So, so the next session is Dr. Kanika and Dr. Satinder. You are the mentors.
Yeah. Hi,
Yeah.
Dr. Swarupa. Yeah. Start.
And
Great,
Dr.
start.
Megha, who is the presenter.
Hello, ma'am. Good evening. I am Dr. Megha, I'm fellow from Max Sakev in Gynae Onco. I'll be talking on today exploring the role of lymph node dissection in management of endometrial cancer. My mentors for this session are Dr. Kanika Batra and Dr. Satinder Kaur. So already much has been talked about the incidence of the endometrial cancer. I will not waste time. So studying about the pattern of lymphatic supply in the corpus uteri, they're basically being drained by the 2 nodes, external iliac lymph nodes predominantly, followed by some lower segment being drained by internal iliac group of lymph nodes, some obturator group of lymph nodes, and the fundus being drained by the para-aortic group of lymph nodes. So to give a wholesome idea of how frequently the lymph nodes get involved in the endometrial cancer, we have done a very quick review of literature in a chronological session, starting from GOG33 trial to 2020 Sucheta et al. Trial. And we divided these these trials into 3 parts: patients with no invasion or less than 50% myometrial invasion, patients with more than 50% myometrial invasion, or patients with extrauterine disease. So the patients with in GOG33 trial, grade 1 or 2 tumors, the lymph node mets was around 5%, increasing up to 15% in grade 3. In Borono et al. Trial, it was less than 1% with no invasion. It was 2% with Chi et al. And in Mariani et al., no nodal mets with grade 1, 2 with no invasion, plus size was when tumor size was less than 2 centimeters. Sucheta et al. Trial, which was done recently in 2020, it was only 5.8%, whereas patients with more than 50% myometrial invasion or in stage 2, the lymph node involvement was reaching up to 40% in grade 3 tumors. And if it was involving outer 1/3 of myometrial invasion, it was reaching as high as up till 25% in pelvic and 17% in para-aortic, 15% in case of endocervical involvement, and 24.3% in case of stage 2 or stage 1B tumors. Extrauterine spread was associated with 46% of the peritoneal disease. So we could conclude that the risk factors for lymph nodes met will be LVSI, histology and the grade of the tumor, size of the tumor, and the peritoneal disease. So studying that does lymph node mets in endometrial cancer have a prognostic factor? Yes. So we studied 3 articles over for this. Morrow et al., Lorraine et al., and Northwestern in 2008. Northwestern study 2008, in which they studied the overall survival. In Morrow et al., there was no nodal mets. It was associated with 90% recurrence-free survival, and it was same for all the studies, more than 90%. But as soon as it was getting involved with the para-aortic mets or the pelvic mets, the overall survival or the recurrence-free survival was less than 50%, as low as up till 31% in Lorraine et al. Study. So the key point in this about this review of literature was that patients with lymph node mets have an almost 6-fold higher likelihood of developing recurrent cancer compared to patients without lymph node mets. And just a brief discussion about what are the standard care of practices in endometrial cancer according to NCCN. NCCN says if the patient is suitable for primary surgery, is resectable, and is pelvis confined, patient is upfront for upfront surgery, that is THBSO plus surgical staging. And if the stage 2, that is the endocervical involvement of cervix, then the type of hysterectomy will be radical hysterectomy. And if it is higher stages and it is surgically resectable, then optimal debulking is the answer. So we will explore the role of lymph node dissection in 2 parts. Lymphadenectomy as a part of surgical staging and lymphadenectomy as a therapeutic role. So the key question for the surgical staging is whether lymph node dissection confers a survival benefit to patients in low grade or in early stage disease. So we again had a review of literature of major breakthrough trials during the time period, starting from Mayo's criteria from 2000 up till to the FIRES trial. So Mayo's criteria, it was a retrospective study, and it identified that the low risk patients for lymph node mets grade 1 or 2, less than 50% myometrial invasion, or size was less than 2 centimeters. These are the low risk for lymph node mets. And they also had an article regarding their experience with systematic PLND, and they highlighted the role of systematic PPLND in their retrospective study. Mayo in 2008 did a prospective study, and they re-exercised the role of systematic PPLND and a must in excising the gonadal veins along with the PPLND. Then there was a consort trial in 2008. It was an RCT, and they showed that pelvic lymphadenectomy cannot be a blanket treatment to all. CPAL study and Senti-Endo study was a further upgraded study involved, Senti-Endo study in which they also highlighted the role of sentinel lymph node as a trade-off between the lymph node as no lymph node dissection and pelvic or para-aortic lymph node dissection. They identified the role of sentinel lymph node biopsy. So coming on to the next 2 breakthrough trials in assessing the lymph node dissection. One is Aztec trial in 2009, and one is the FIRES trial in 2017. And they kind of gave us a clarity regarding no lymph node dissection, sentinel lymph node dissection, pelvic lymph node dissection, along with RPLND. So Aztec trial, the design of the study, the duration of the study was 1998 to 2005. They studied 1,408 patients prospectively with preoperative stage 1 endometrial cancer, and they randomized them to surgery plus minus lymphadenectomy. And to have a control over their post-surgical treatment, they also divided or randomized these patients with early stage disease at high or intermediate risk. That is, if they were grade 3, serous or clear cell, or more than 50% myometrial invasion or endocervical glandular invasion 2A, they were randomized to Aztec Radio 3 trial without taking the lymph node status into the account. The results in which they identified was there was absolute difference. There was overall survival 1% difference in the 2 arms. So it was favoring the standard surgery without pelvic lymphadenectomy, and the recurrence-free survival was, the difference was only 6%, and henceforth favoring the standard surgery. But this study had a lot of limitations, like there was absence of treatment in patients with pelvic nodes that may increase the survival rate in patients with lymphadenectomy arm. Vaginal brachytherapy was permitted regardless of pelvic radiotherapy assignment, and it was based on the institutional preference. poor quality lymph node dissection, and many of the 8% of the patients did not even had lymph nodes received in their final histopathology specimen, and 12% have less than the recommended lymph nodes removed. And there was no RPLND or periodic lymph node dissection in pelvic nodes, which could have increased the survival rate of the lymphadenectomy arm. Next study which came into play was the FIRE study. The design of the study was the eligible patients with clinically stage 1 endometrial cancer of all grades in histology undergoing minimal invasive surgery. Cervical injection of indocyanine green was given. Sentinel lymph node mapping was followed by pelvic lymph node dissection with or without paraaortic lymph node dissection. Negative sentinel lymph node by H&E staining were ultra staged with immunohistochemistry for cytokeratin. Results were 86% had successful mapping of sentinel lymph node. 41 out of 340 patients had positive lymph nodes, and out of these 41, 36 were successfully mapped with sentinel node. So the sensitivity of sentinel lymph node dissection was 97.2%. Negative predictive value was 99.6%, which is too high, and false negative rate was very less, that is 2.8%. So they concluded that sentinel lymph node mapping with ICG has a very high diagnostic accuracy. Sentinel lymph node mapping can safely replace lymph node dissection in the staging of endometrial cancer, and SLN mapping will not identify 3% of the patients, okay, but they will expose fewer patients to the morbidity. So this is a short stint as to how SLN mapping is being done. We at our institution inject the sentinel orogry dye at 3 and 9 o'clock position. And the most common location of the sentinel lymph nodes following the cervical injection are toward in this area, that is in between the external and the internal iliac arteries in this basin. And the less common lymph node that is being identified are usually the lymphatics which are not crossing the umbilical ligament but along the mesoureters and in the presacral and the common iliac region. So considering all this, in our institution, we also subject all the sentinel lymph nodes to the ultra staging, and hence the treatment is guided. Lymphadenectomy as a therapeutic role. We have studied till now the staging role of lymphadenectomy. Where does they have a therapeutic role? Therapeutic role is in which there are gross nodal disease clinically or radiologically, stage 1 or 2 with LVSI or grade 3 tumors, serious and clear cell tumors, and evidence of local spread of peritoneal disease. Chan et al. Did a database study on close to 40,000 women with endometrioid endometrial cancer, and he divided these patients into two arms: the patients in which lymphadenectomy was done and in the patients in which lymphadenectomy was not done, and it was further subdivided according to the stage 1, 2, 3 of endometrial cancer. We can see in stage 1, it hardly mattered whether the lymphadenectomy was done or not. The specific survival is almost the same. But in stage 3 or 4, there is more than 10% difference in the disease specific survival in the lymphadenectomy arm. It has more survival rates. So to keep the things easy and to give us more clarity, ESMO 2021 give us some recommendations. Sentinel lymph node biopsy can be considered for staging purposes in patients with low risk patients, and systematic lymphadenectomy is not recommended in this group. Surgical lymph node staging should be performed in patients with high intermediate risk or high risk diseases, and sentinel lymph node biopsy can be an option for these diseases for lymph node staging in stage 1 and 2, level of evidence 3. It is as per the clinical experience of the surgeons. If sentinel lymph node biopsy is to be performed, then if in a site-specific sentinel is not identified, then site-specific systematic lymphadenectomy should be done. And all the sentinel lymph nodes should be subjected to ultra staging of sentinel lymph nodes. The sentinel ultra staging can be more clearly explained by the pathologist, but ultra staging is very thin serial sectioning of the lymph nodes up till 2 mm, and then further sectioning and subjecting each slide to both H&E as well as to the IHC staining, if I am not wrong. Then when a systematic lymphadenectomy is performed, pelvic and para-aortic infrarenal lymph node dissection is the one which is suggested. Presence of both macromets and micromets, that is less than 2 mm, is regarded as metastatic involvement. Here is the role of sentinel lymph node ultrastaging. Ultrastaging can detect up till more than 15% of micromets and can upstage the disease. That is why the role of sentinel ultrastaging has come. The prognostic significance of isolated tumor cell is still uncertain. Adjuvant therapy is still not decided over this issue. And if pelvic lymph node is found intraoperatively, further systematic pelvic lymph node dissection and para-aortic dissection should be considered. So these are the general consensus of the ESGO-ESMO, but as to how pathologists would want us to do the lymph node sampling. The lymph nodes from different anatomic sites should be sent in the container separately, labeled with proper location being told. They should be carefully dissected from the adipose tissue. This can be done through thorough physical examination and palpation. A small amount of adipose tissue should be left around the larger lymph nodes so as to evaluate the presence or absence of extranodal extension. And the description of the sentinel lymph node should involve the gross measurement and also how much dye and or the presence, whether it was diffuse uptake of the dye or it was a proper uptake of dye, that should be mentioned in the paper. So we have explored the role of lymphadenectomy through our literature, but the question arises as to why we have restricted the lymphadenectomy to the intermediate or the high risk types. The answer is the potential long-term benefit, long-term effects. Intraoperative vascular and nerve injury, lymphocyst formation, lymphocyte formation, though it can be managed and it is less than 1%, but the major disabling condition is the lymphedema, which is up till around 5.8% in those with systematic PPLND. And adjuvant pelvic external beam radiation and dissection of more than 31 lymph nodes can be the risk factors for development of this lymphedema. So coming on to the recent advances, as my friend has already discussed in detail about the TGCA classification and the molecular classification, does this molecular classification has an impact on tailoring our lymphadenectomy? We have no literature over this. But with current recommendations of molecular testing on the curating samples, in the sample in which we have a good curatings and molecular testing can be applied on that, risk stratification can be done preoperatively. That can be our vision. And though there is no literature, but it can help guide the preoperative surgical planning and counseling of the patient. So my take-home message through this presentation is there is role of sentinel lymph node. I'm sorry, there is an error in this. There is a role of sentinel lymph node biopsy in early stage and low risk endometrial cancer. Systematic lymphadenectomy is method of choice in high risk groups. And in high risk groups, it should be accompanied by the sentinel lymph node dissection also, because sentinel lymph node dissection along helps to map the lymph nodes as well as to harvest more lymph nodes. There has been many studies which denote that, and it helps detecting micromets more. Sentinel lymph node can be a good standoff between no lymphatic lymph node staging versus complete lymphadenectomy. And with molecular TCGA classification and risk stratification, the extent of lymphadenectomy can be tailored, but there is no literature regarding it. Thank you.
Thank you, Megha. I think Megha has made the things quite clear and she has given a very illustrative presentation and clear-cut guidelines on when lymphadenectomy is to be done and when it is not to be done. And as she said, yes, for early stage tumors, low risk, you may not do any lymphadenectomy, but if you have the option of sentinel lymph node dissection, you should go in for sentinel lymph node dissection, because there are 15% chances of micromets, and we might actually find out the patients which may have been missed if we just do not do a lymph node dissection for stage 1A, grade 1 and 2. And for intermediate and high-risk patients, lymphadenectomy is suggested. And if you have If the tumor is limited to the uterus, if it is a uterine confined disease, then sentinel lymph node dissection is an option even for high-risk tumors. And as she said, as of now, molecular classification does not modify our surgical treatment, but yes, time may come when we have more data, like for pole mutations, which are high-risk tumors, we may avoid the lymph node dissection. And for even endometrioid, which are P53 positive, we might need to do a complete pelvic and para-aortic. But as of now, as she said, we do not have any literature regarding this. So any questions are most welcome. And Kanika, if you want to add something to it, I think.
Madam, I have a question.
Yes.
Hello. There is a case in which localized endometrial tumor with a small focus in the bone, in the pelvic bone. So the uptake is in both in PET CT and also on the MRI. So we have started with the neoadjuvant chemotherapy, considered to be as a stage 4. After 3 cycles of chemotherapy, there is a good response of to the tumor.
Sorry, I didn't get your question. It was just on the PET. On the basis of PET, you have started with chemotherapy.
Not with on MRI also.
But it wasn't biopsy proven.
No,
The
it
node
cannot
was
be
not
biopsy proven. It cannot be biopsy proven.
Cannot be in the sense.
Because that the lesion is the deep in the pelvis. So biopsy, FNS is not possible.
So only one
case.
lymph node. On the basis of one lymph node, you've started with
Not a lymph node.
Yeah.
Not a lymph
Suspicious
node.
bone lesion.
Bone lesion. Okay.
Single bone lesion.
Yeah.
Okay. And after chemotherapy, there is a very good response to the chemotherapy. So we go ahead with the surgery. Now, in this case, whether we should go for the pelvic lymph node dissection or not?
So, Kanika, would you like to take or?
Yeah, I mean, actually, I'm really unclear. Firstly, what was the grade of the tumor, if you could repeat?
Grade 2, endometrioid.
Grade 2 endometrioid. Otherwise, it was uterine confined, but there was a single bony met, is what you're trying to say.
Yeah.
Okay, so we can actually take this question, but firstly, I just wanted to tell about this basic lymph node thing that we were discussing about. We'll just address this also. Just one thing that I wanted to say about the lymph node, as Megha had presented, for the benefit of all the students that we have, I need to say this, that no frozen section needs to be sent of the sentinel lymph nodes. This needs to be ingrained in your head because it is very different from how breast cancer sentinel lymph node is there. We need to be really, this should be drilled in our head that in endometrium, we don't send it for frozen section. We directly send it for ultra staging, at which, 2 mm depth, they cut it and they put immunohistochemistry over there. And there is a proper mapping algorithm that needs to be followed, in which, in case you do not find any sentinel lymph node, you need to go ahead and do complete lymphadenectomy. And since we do not send it for frozen, we do not do completion lymphadenectomy ever in endometrium like it is done in breast. And in the high risk group, it is important to do both sentinel and complete. As of now, we don't have a lot of convincing data with respect to complete lymphadenectomy to be done. And especially, the lymph nodes above the level of inferior mesenteric artery, they need to be addressed. So these things need to be, particularly ingrained. So now coming on to the role of cytoreductive surgery in CA endometrium in stage 4, which is an oligometastatic disease. So typically something that is grade 2, it needs to be addressed if it would have been addressed with just, sentinel lymph node, but because it has a bony lesion, and this is a very difficult situation to answer because you haven't biopsy proven the met that is there, but since it is responding, so retrospectively we can kind of assume that a lytic lesion, if it has become sclerotic now or it has disappeared, that it was probably tumor that was there and it has now responded. So it needs to be dealt in an aggressive manner, in the sense of doing a complete cytoreductive surgery with lymphadenectomy, pelvic and para-aortic, and doing, a proper staging that ways. And if since we couldn't even biopsy, otherwise if the bony lesion could be dealt in a better way, but it needs to be dealt in an aggressive way, given the fact that there is metastasis through blood. So there are higher chances of some micromets being harboring in the node as well.
So
Actually,
as I
what is
understand, the bone lesion has not responded. The tumor primary.
no.
So
The
see,
bone
what I feel that there is a
bone
role of
lesion has
molecular
responded to a
classification.
chemotherapy.
Yeah, so there is a role of molecular in this setting. You should have done markers. If it was P53 positive, you could have thought it to be aggressive tumor. And maybe, and if it was P53 negative, it could have been considered to be a low grade and you should have gone for a surgery first. And the bony lesion could have been covered in the adjuvant radiation if it was required. If it was later on thought to be, if it was increasing in size by the time, we would have waited for at least a month post-surgery. If we would have, because we were not able to biopsies. So we really don't know whether it was actually a MET or not. And a limited disease, endometrioid grade 2, I am really not sure whether we should treat it like stage 4. I think it should have been treated like an early stage tumor. We should have gone in for surgery first. And if it had other aggressive features also, like lymph node mets came in later on or something, other associated factors, we could have taken it to be stage 4. But initially, I would recommend you should have done, you can still do a P53 on it. If it is P53 positive, you should go in for lymphadenectomy. And if it is negative, then you should actually, if possible, go for a sentinel lymph node. If it is negative, consider it to be an early stage disease. I think chemo is an over treatment. That's my opinion. Maybe.
Also, Dr. Satinder, I agree with you in terms of the molecular marker, but just the fact that she's received neoadjuvant doing sentinel now makes it a little dicey.
Yeah. So I am not happy with the initial.
Yeah.
I am not sure whether it was initially stage 4 to begin with. Maybe Dr. Swarupa can comment. What do you think? Do you think we should take it like a advanced stage disease, or we should?
I agree. No, the molecular markers would have made a hell lot of a difference in this. So it should have been done earlier. So, and even now, as you said, yes.
Even now, if you're planning for surgery, even now you can, on the DNC specimen, you can do and accordingly.
Treatment. Yes, absolutely.
Yeah.
So I think we move on to the next session.
Thank you.
Thank you.
Great session. And we move on to the next. And we are running about 15 minutes late. So Gerim and Dr. Manoj, your session begins. Manoj, sorry, Dr. David and Dr. Jayalakshmi. So Dr. Gerim. Yeah, go ahead, Dr. Gerim.
Thank you, ma'am. Good evening, respected teachers and my colleagues. So we have discussed in detail about the molecular characteristics of endometrial carcinoma. Now let us discuss about the importance of the incorporation of molecular characteristic in management of endometrial carcinoma, mainly in adjuvant setting. So
there is a different.
So we know that endometrial carcinoma, it is so we know that the endometrial carcinoma, it is a histologically and molecularly heterogeneous cancer, and the molecular classification, it has both prognostic and predictive value. So why do we need molecular classification? In the landmark trial POTEC-1, which was done in 1990 to 1997, where they took stage 1A, grade 1 to grade 3, and in stage 1B, they took grade 1 and grade 2 and randomized into adjuvant EBRT versus observation. They found that there was benefit with EBRT in high-risk intermediate group. So when the 15-year distant metastasis was seen, it was 9.3% in that subgroup. So this shows that in stage 1 disease also, small population of patients have bad prognosis. So in continuation, when POTEC-2 was done from 2002 to 2006, when they randomized to adjuvant EBRT versus adjuvant intravaginal brachy, and the local regional recurrence was similar, they found that the 10-year distance metastasis among those patients was 8.9% to 10.4%. So it came to conclusion that there is small proportion of early stage disease that do have bad prognosis, and this can be beyond the stage, beyond the risk classification. So probably this may be due to its molecular characteristics. So this led to the in 2013 to the Cancer Genome Atlas, where they further divided endometrial carcinoma into pole E ultramutated microsatellite instability hypermutated, copy number low, and copy number high. So during POTEC 1 and 2, the molecular classification had not come into existence. So in 2016, Stello et al., he evaluated the tumor blocks of POTEC 1 and 2 and did molecular analysis in more than 96% of the patients. So he found that in 59% of the population, they had no specific molecular profile. And in 26% of the population, it was microsatellite unstable. In P53 mutant was seen in 9% of the population, and POL-E mutation was seen in 6% of the population. So he did this to see the prognosis of these patients. So altogether, 49 patients were there who had POL mutation in POTEC 1 and 2. So they did not have any locoregional recurrence, and the 5-year disease-specific survival was 100%. And they then thought, what would be the prognosis of the patient who got only observation, who were only in the observation arm, and then they were POL-E mutated. So they further analyzed in POTEC 1, and they took stage 1 intermediate risk endometrial carcinoma in the observation arm only. And they saw the 10-year recurrence-free survival. It was seen that in POL-E mutated cases, there was 100% 10-year recurrence-free survival, while as compared to the POL-E wild, it was only 80.1%. So this showed us the excellent prognosis of early stage POL-E mutated CA endometrium in observation arm only. So this is the Kaplan-Meier analysis having ABCD curve. Let's focus in the D curve, that is the overall survival. In x-axis, it is the time frame, and then y-axis, we have the overall survival. The red dotted line is the P53 mutated, and POL-E mutated is the blue line. So here we can see there is worse prognosis of P53 mutated cases as compared to POL-E mutation. So in this study, they also saw about L1-CAM, that is L1 cell adhesion molecule, and found out that in patients who had more than 10% L1-CAM mutation, who had substantial lymphovascular space invasion, that is more than 4 involved vessels, or if the patient had P53 mutation, they all did poor prognosis. Locoregional recurrences were high, and they had high distant metastasis. So POTEC 3 was another historical study in which they had randomized the high-risk endometrial carcinoma patients into EBRT alone versus CCRT followed by adjuvant chemo. So in this trial, they took stage 1 and 3 non-endometrioid histology, and of endometrioid histology, they took stage 1B, grade 3, stage 2, and stage 3. So when they randomized and saw the results, the population who got CCRT did better. So in 2020, TransPOTECT Consortium, they further evaluated the cases of the POTEC 3 patients. So in that, they did IHC for P53 and MMR proteins and DNA sequencing for POL-E mutation, and further divided those POTEC 3 population into 4 groups. So what they found was the 5-year recurrence-free survival in those patients who had who received CCRT plus adjuvant chemo was 59% in P53 abnormality, whereas the 5-year recurrence-free survival in the arm who received radiation alone was 36%, with statistically significance. So we can see that chemotherapy had better, with the addition of chemotherapy, P53 abnormal endometrial CA patients did better, while in other cases, like in POL mutant endometrial carcinoma, MMRD or NSMB, it was not statistically significant. So this study showed that the incorporation of the molecular classification into risk stratification is essential, and this should be incorporated in the management. So further with POTEC 1, 2, and 3, so prognosis was shown. It was those patients who had POL-E ultra mutated, they had good prognosis, while patients with MMRD or copy number low, they had intermediate prognosis, and the patients with P53 mutation, they had bad prognosis. So then the confusion was there, if the patient has more than one molecular classification, what will be the clinical behavior in those patients? So multiple studies was done, and in 2020, Castillo et al. Clarified the doubts. What he did was they obtained patient data and tumor tissue from endometrial carcinoma of more than 3,000 patients. So in that, they found in 138 patients, that is 3.9%, they had more than one classifying feature. So after doing quality control and including central pathology review, he excluded 35% of the cases due to various reasons. So out of 3.9, only 3% of the tumors displayed multiple classifiers like MMRD with P53 abnormality, POL-E mutation with P53 abnormality, and all three mutation. However, in this study, they had omitted MMRD and POL-E mutation. So further, he saw the recurrence-free survival. So here we can see this is for POL-E mutation and P53 abnormality versus P53 abnormality only. So this x-axis is the time frame and y-axis is the recurrence-free survival. So they found out that if the patient had both the mutation, that is POL-E and P53, they had better recurrence-free survival as compared to only P53 abnormality. And similarly, in MMRD and P53 abnormality, this group of patients did better. So with P53 abnormality only, the 5-year recurrence-free survival was 70.8%, while for patients in which MMRD and P53 abnormality was there, the 5-year recurrence-free survival was 92.2%, and in patients with POL-E mutation and P53, it was 94.1%. So this gave us the conclusion that patients with both MMR deficient and P53 abnormality tumors, we need to go with MMR deficient. The clinical behavior, it acts like MMR deficient, and in those patients where both have POL-E mutation and P53 abnormality is present, the prognosis is similar to POL-E ultra mutated. So we need to treat like that. So with these all groundbreaking trials, various guidelines were published. So in 2020, ASGO Astro guideline was published. In June 2022, ESMO guideline was published. And in December 2022, this Astro guideline was published. So they all had similar recommendations, and they incorporated molecular classifications in their guideline. So this was discussed initially also. So I would like to highlight here that this was the initial classification without knowing molecular classification, and this is with molecular classification. So even though patient is in stage 2, if patient has POL-E mutation, then she will fall under low risk group. While if patient is in stage 1, but she has P53 abnormality, then she will fall in high risk group. So the molecular classification incorporation has changed the risk characterization. And here we can also observe that if patient has MMRD or NSMB molecular characteristic, then this does not change the risk stratification. So according to the ESMO 2022, here we can see if patient is in low risk group, that is patient is in stage 1A, that is less than 50% of the myometrial invasion, grade 1 or grade 2, that is low grade, with endometrioid histology, with no or focal lymphovascular space invasion, and if the molecule classifies as MMRD or NSMB, then adjuvant therapy is not needed. While in patients with stage 1-2 POL-E mutation, again, the adjuvant therapy is not needed. So here we can emphasize that even in stage 2, if there is POL-E mutation, then adjuvant therapy is not done. So we can de-escalate the treatment. And for patients with stage 1A, grade 3, endometrioid histology with MMR deficient or NSMB with no or focal lymphovascular space invasion, only adjuvant vaginal brachy can be given. In patient with 1B, grade 1 and grade 2, DMMR or NSMP with no or focal lymphovascular space invasion. Again, only vaginal brachy is recommended. For patient with stage 2, grade 1, endometrioid histology, MMRD or NSMP with no or focal lymphovascular space invasion, again, adjuvant vaginal brachy is recommended. However, here we can see that this is stage 1A, that is less than 50% of myometrial invasion, but P53 abnormality is there. So patient is in intermediate risk. But in this case, if there is no myometrial invasion, then adjuvant therapy is not recommended. So this is also major change. So this is from ESGO-ESTO. It has shown that for patients with low risk endometrial carcinoma, no adjuvant treatment is recommended as discussed earlier. However, in patient with endometrioid carcinoma stage 3 and 4A with pathogenic POL-E mutation, there are no outcome data with the omission of adjuvant treatment. So in these cases, now at present, we do give adjuvant therapy. Similarly, in intermediate risk, adjuvant brachy can be recommended to decrease the vaginal recurrence as per POTEC-2 trial. Omission of adjuvant brachy can be considered if patient's age is less than 60 years, because 60 years we have kept as a risk factor. So when molecular classification is known, POL-E mutation and P53 abnormality with myometrial invasion have specific recommendations. As discussed, in POL-E, we'll observe, while in P53 abnormality, we'll go with CCRT. And this has been discussed. So let's see about the high intermediate risk. So if the patient is in stage 1A, 1B, but substantial lymphovascular space invasion is there. So this is risk factor 1B with grade 3, 2 grade 1, substantial lymphovascular space invasion, or stage 2, grade 2 and 3 with MMRD or NSMP, then adjuvant EBRT is recommended. And all stages and all histologies with P53 abnormality and myometrial invasion, all stages with serous or undifferentiated carcinoma, including carcinosarcoma with myometrial invasion, and all stages of stage 3, 4A, regardless of histology and regardless of molecular type, EBRT plus concurrent chemo followed by adjuvant chemo is recommended. So here we can also see EBRT can be considered for substantial lymphovascular space invasion and stage 2. Adjuvant chemo can be considered especially for high grade and substantial lymphovascular space invasion. So when molecular classification is known, POL-E and P53 abnormality, they do have specific recommendations as discussed. So similarly, EBRT plus concurrent and adjuvant chemo, or alternatively sequential chemotherapy and radiotherapy is recommended. So this will be discussed in further classes also. And chemotherapy alone is also an alternative option. So and carcinosarcoma should be treated as high-risk carcinomas. So there are many upcoming trials like POTEC-4A, TAPER, and Rainbow trial, which will help us to further escalate as well as de-escalate the treatment, so as to decrease the over-treatment as well as under-treatment. So let's see here the study design of POTEC-4A. So here they have taken stage 1 high intermediate risk endometrial carcinoma, and they have subdivided with the molecular classification. We can see here they have also taken L1 CAM and CTNNB1 in their categorization and divided into favorable, intermediate, and unfavorable. So for the patients having favorable, falling in favorable group, only observation is done. For intermediate, vaginal brachy is given, and for unfavorable, EBRT is given. So this is the experimental arm. So the results of this POTEC-4A is awaited. So the upcoming trials are expected to give promising results. And in the era of personalized and precise treatment, molecular classification helps us to individualize the treatment. Thank you.
Yeah, that was a very extensive presentation, Dr. Jaren. Good. As of now, when we see the impact on clinical decision making, in particular, if you look at adjuvant treatment, in particularly radiation, it's not made an impact in the low risk cancers. Okay, low risk cancer, low risk endometrial carcinoma, there's no significant impact. The question arises, as well as we're all waiting, is about the high intermediate risks. So in the high intermediate risk is, and the POTEC 4A is exactly addressing that. The best part of POTEC 4A is it is taking all, it is restricting itself only to the high intermediate risk. Whereas if you look at the other trials and all, they are going through the stages and through grades also. So to answer, in the high intermediate risk, are we going to do further molecular classification and then decide? I don't think it's started to come into practice more, but yes, as we start using, that is when we can. It is that area where it has to be addressed. And the other area where it could make an impact is in the pre-op also, because this molecular classification can be a surrogate even on the biopsy. It's not necessarily that we have to do it only in the post-operative setup. So it may change our decision making, in the pre-op setup. And so prevalent use of this even by gynecologists is what is going to give an answer. Any other comments, Dr. Dev?
Thank you, ma'am. Garim, it was an excellent presentation. I just wanted to highlight a few points. What we do over here in our institute, most of our patients do undergo molecular classification, mostly P53 and other markers. In selected patients, we do go for polymutation as well. But for the residents, I would like to highlight, the only changes that has happened right now, it is regarding the polymutation and the P53. In certain patients in stage 2, where we would have escalated the treatment otherwise, if the polymutation is positive, then we can de-escalate and go for observation only. But again, this is restricted only for stage 1 and 2. If a patient with stage 3 cancer comes, and if a polymutation is positive, then we do not have the literature to say that we can go for observation. This is one point. Second point is, as Dr. Garim said, if a P53 mutation is positive, even if it is a stage 1, you have to escalate the therapy, because it has been seen in in the POTEC 3 trial. Even those patients who were in stage 1, when they had P53 mutation, they had distant metastasis. So this has to be kept in mind. Even a stage 1 patient, if a P53 mutation is positive, then you have to escalate the therapy by saying that you have to add chemotherapy. Another thing that I would like to highlight is for the LVI. At many places, the importance of LVI is not highlighted. It is very clearly said in all guidelines that you have to mention it as a focal LVI or is it a substantial LVI. And different guidelines say different things. I think ESGO says it is more than 4 vessels. If it is involved, then it should be called substantial. If it is ASTRO says that if it is more than 5. So whatever it is, you have to request your pathologist to mention whether it is a focal or a substantial LVSI, because it changes the management, it changes the risk stratification of the patient, and based on that, you will change your management, especially in the intermediate risk group. And we haven't discussed more about the molecular impact on the metastatic setting. That is a different class altogether. I think that's it. If anybody has any questions, they can ask.
David.
Yes, ma'am.
We are incorporating all the molecular data in our management.
Yes, sir.
Now, if it is a stage 2 PON mutated, whether we will put the patient on observation, this is a big question.
Yes, sir, we do.
You do, and even the cervix is involved. If POL is mutated, then you keep on that patient under observation.
That is what the literature says and the guidelines says, sir.
Says. But do you have, we have enough data for that?
So the POTEC 1 trial and POTEC 2 trial, when they combined it and do the analysis, they did say that stage 2 patients, even on the observation arm, they did not have any recurrences. 100% had 100% of the patient had complete recurrence-free survival.
And Manoj, we are doing a small study in our hospital. Till now, we had 89 patients. We have it's based on the POTEC 4, and we have found only 1 poly positive. So it is very difficult to decide based on that, because two less, that makes about 7%. But one patient we had, we did not give her any adjuvant treatment.
And usually these patients will be grade 3 patients.
Yes, they are grade 3, yes.
Okay, then that is, madam, that is okay. But what I feel that in a stage 2 cancer in which there is a very high chances of having the pelvic lymph node positivity, to not to give adjuvant radiotherapy in which we do not have the robust data is, I would say, it's very difficult to do that.
Yeah, right now actually, it is too early, but yes, we are learning.
Okay.
Because we are still poorly mutated stage 1, stage 2, everywhere it says it's very good prognosis. And like I said, very few cases, I think we are an countable number of patients we are getting poorly mutated. So they're supposed to be very good prognosis. So maybe we'll become more confident. Right now, we are not used to that idea. So maybe we'll be more confident in letting these patients go without any treatment, adjuvant treatment.
The literature says around 7% of patients are polymutated, but what we actually see is less than 3 or less than 2%. And all these patients are grade 2. Whichever patient came out to be positive, they were all grade 3 patients.
Yeah. I think we move on to the next session, that is the debate. And we have our mentors are Dr. Manoj Sharma and Dr. Deni. And we have, the topic is debate on adjuvant treatment of high-risk endometrial cancer. And this is again a debate in our clinics, chemoradiation versus chemotherapy. And Dr. Komal Mittal, she is a DNB radiation oncologist, and Dr. Ashutosh, he is a DNB medical oncologist in Dharamshala. So Dr. Manoj and Dr. Deni, you are the mentors. Dr. Komal, you can share your screen.
Yes, ma'am. Ma'am, am I audible?
Yes, yes.
Yes.
Do share your screen. We can't see your screen.
Ma'am, is it visible?
No,
No.
not yet.
Ma'am, is it visible now?
Yes, yes, its screen is visible. Yeah, that's right. That's right.
Yes. Good evening, everyone. I'm Dr. Komal, second year DNB resident at Action Cancer Hospital. And my topic for today is adjuvant treatment in high-risk endometrial carcinoma with chemoradiation. Though the primary treatment of endometrial cancers is surgery, adjuvant treatment is decided on the basis of certain clinicopathological factors such as age, grade, histological type, depth of myometrial invasion, and lymphovascular space invasion. As we are already well versed with the FIGO staging, so I'll be skipping these slides. Earlier, endometrial carcinoma was divided into 4 risk groups on the basis of certain risk factors that were grade 3, more than 50% myometrial invasion, age more than 60, and the presence of lymphovascular space invasion. Low risk group included grades 1 to 2 with no or less than 50% myometrial invasion. Intermediate group included either grade 3 with no or less than 50% myometrial invasion or grades 1 to 2 with more than 50% myometrial invasion. High intermediate group was intermediate with the presence of LVSI or with age more than 60 years. High risk group included grade 3 with the presence of more than 50% myometrial invasion. But with the advent of molecular factors such as pole mutation, mismatch repair deficiency, or the microsatellite instability, and P53 mutation, ESMO updated its guidelines in 2022, which incorporated molecular subtypes, histological types, and the substantial LVSI into defining the various risk groups. For reference, substantial LVSI is considered the presence of LVSI in 4 or more vessels. As these are already discussed So I'll be straight away coming to the high risk group. High risk group includes all the stages and histologies with P53 abnormality with myometrial invasion, all stages with non-endometrioid histologies with myometrial invasion, and stages 3 and 4A with no residual tumor irrespective of the histology and the molecular subtype. Based on these risk factors, ESMO also updated its guidelines on the adjuvant treatment. So low risk was recommended to observe. Intermediate risk group was suggested to be given vaginal brachytherapy. High intermediate risk group was considered for external beam radiation, and the high risk group, the standard recommended treatment in the high risk group was external beam radiation with chemotherapy. So now I'll be quoting some of the trials supporting my previous few of the slides. As we all know, POTEC-1 was the first trial to show the role of external beam radiation in reducing the local regional recurrences in high intermediate and high risk group. GOG-99 was the trial which led to similar results. As external beam radiation led to increased complications, so POTEC-2 concluded that vaginal brachytherapy was equally beneficial in preventing the vaginal recurrences and also improved the quality of life in intermediate and certain high intermediate risk groups. Swedish trial also led to similar results. Now POTEC-3. POTEC-3 was among the few major trials that incorporated chemotherapy into the adjuvant treatment of endometrial carcinoma. It randomized high-risk group patients into two arms, pelvic RT versus pelvic RT with chemotherapy. There was significant improvement in both the 5-year overall survival, that was 5%, and the failure-free survival, that was 7% in the high-risk group. But women with serous cancers benefited the most, with an absolute improvement of 19% in the overall survival and 12% in the failure-free survival, which concluded that stage 3 and serous endometrial carcinoma benefited the most with the addition of chemotherapy with radiation therapy. POTEC-3 revised its results considering the molecular subtypes and concluded that adjuvant treatment can be de-escalated in patients with pole mutation, and patients with P53 abnormality should be considered for the addition of chemotherapy. Though the data are not yet completely available for the mismatch repair deficiency, so we need additional data regarding that. These are few of the trials that incorporated chemotherapy as the adjuvant treatment in the endometrial carcinoma. Among these, GOG-258 was the only trial that randomized patients into pelvic RT along with chemotherapy and chemotherapy alone. Though there was no significant difference in the 5-year overall survival and progression-free survival in both the arms, but the chemo alone arm led to more locoregional recurrences, and also grade 2 and grade 3 hematological toxicity was more in the only chemotherapy arm. Even on 3-year follow-up, grade 3 peripheral neuropathy was seen in only chemotherapy arm, which affected the quality of life. POTEC-4A, it is the first trial to introduce the molecular factors in the adjuvant treatment of the endometrial cancers, though the results are still awaited, but the results will surely answer many questions regarding the escalation and de-escalation of adjuvant treatment on the basis of molecular classification. So I'd like to conclude my talk on though we can skip the adjuvant treatment in low-risk endometrial cancers, but the patients that are at higher risk of locoregional and distant metastasis require both chemotherapy and radiation therapy. There are no data till now that recommend potentially toxic chemotherapy alone in the high-risk endometrial carcinoma. So, radiation therapy remains the standard of care in the management of high-risk endometrial cancers, though chemotherapy can be added with radiation therapy in patients with P53 mutation with myometrial invasion, non-endometrioid histologies with myometrial invasion, and FIGO stages 3 and 4A for additional benefit. Thank you.
Thank you, Dr. Kamal. Very nice presentation by you. And it clearly showed that there is no role of only adjuvant radiotherapy in the case of CA endometrium. It can be with the radiation in certain cases, high risk cases like P53, stage 3, and non-endometrioid histologies. So let us see how our medical oncology people defend this fact. Over to Dr. Denny. Hello.
I think Dr. Manoj and Dr. Manoj, let us first be presented by the Dr. Ashutosh. Yeah, then we can discuss. Yeah. Dr. Ashutosh, you can start this.
And my slides are visible.
Yeah.
Okay. Good evening, teachers and fellow participants. I am going to give my arguments in favor of key role of chemotherapy in adjuvant treatment of high-risk endometrial carcinoma. So, as this has been discussed already, I'm just going to give a small introduction that in the recent ESMO clinical practice guidelines, high-risk endometrial carcinomas have been classified as all stages and all histologies with P53 abnormality and myometrial invasion, and all stages with serious or undifferentiated carcinoma, including carcinosarcoma with myometrial invasion, and all stage 3 and 4A with no residual tumor, regardless of histology, and regardless of molecular subtype. So I'm going to start with the trial GOG 122, which was published in 2006, which was a randomized phase 3 trial compared whole abdominal radiation with the chemotherapy, doxorubicin and cisplatin in FIGO stage 3 and 4 endometrial carcinoma of any histology were taken in this trial, and eligibility required that total abdominal hysterectomy and bilateral salpingo-oophorectomy was done, surgical staging was done, and there was no single site of residual tumor more than 2 centimeters. Enrolled patients were started on treatment within 8 weeks of surgery, and performance status was less than 3. So, in whole abdominal irradiation arm, irradiation dose was 30 gray and 20 fraction with a 15 gray boost, whereas in chemotherapy group, the dose was doxorubicin of 60 milligram per meter square and cisplatin 50 milligram per meter square every 3 weeks for 7 cycles, followed by 1 cycle of cisplatin. And the results showed, at the time of final analysis, 51% patients were alive in chemotherapy arm versus only 38% in whole abdominal irradiation arm. And the adjusted hazard estimate showed that there was in 13% increase in survival at 60 months in chemotherapy arm versus only whole abdominal irradiation patients, as we can see in this graph. Then 2 years later, Japanese gynec oncology group published another randomized phase 3 trial in which they divided compared patient into pelvic radiotherapy to platinum-based combined chemotherapy for improvement in PFS and OS of endometrial carcinoma. So the eligible patient was FIGO stage 1C to 3C endometrial carcinoma with deeper than 50% myometrial invasion, and the patient should have been with less than 75 years of age and performance status of 0 to 3. Treatment started within 4 weeks of surgery. In pelvic radiotherapy, the scheduled dosage was 45 to 50 gray given within 4 to 6 weeks, and irradiation subsequently additional irradiation were performed in 11 cases with para-aortic lesions and 6 patients who received brachytherapy. Chemotherapy received cyclophosphamide, doxorubicin, and cisplatin every 4 weeks for 3 or more courses. And when we took the whole population, there was no statistically significant difference in PFS and OS in pelvic radiotherapy versus chemotherapy group. However, in 120 patient in high risk and intermediate risk group of patient, there was both benefit in PFS as well as in overall survival in high and intermediate risk group of patient in chemotherapy only arm. So in 2019, PROTECT 3 trial was published, which investigated the benefit of combined adjuvant chemotherapy and radiotherapy versus pelvic radiotherapy alone. Women with histologically confirmed endometrial carcinoma with FIGO stage of 1A grade 3 with documented LVSI, 1B grade 3 stage 2 disease, stage 3 and 3B or 3C and stage 1A to 3 with serous or TSL histology, patients were taken and performance status of the patient should have been less than 2. There were 2 arms and the EBRT with the 48.6 gray in 1.8 gray fraction 5 days a week was given, and in case of glandular and stromal cervical involvement of both, brachytherapy boost equivalent to 14 gray and 2 gray fraction was given. In arm B, in addition to EBRT as above, 2 cycles of cisplatin administered intravenously in first and fourth week, followed by 4 cycles of carboplatin AUC 5 and paclitaxel 175 mg per meter square intravenously at 21 day intervals were given. Chemo started within 3 weeks of EBRT, and this was the result. There was benefit of in overall survival as well as the failure-free survival. This was the first time that it was shown that addition of chemotherapy to the radiotherapy was giving an overall survival benefit and failure-free survival in high-risk endometrial carcinoma. However, in this trial, there was no arm where chemotherapy only was given to the patient. So comes the GOG 258 trial, which was published in 2019 only. This was a randomized phase 3 trial in which patient more than age of 18 years with no more than 8 weeks later from the date of surgery with performance status of 2 or less with having surgical stage of stage 3 and 4A endometrial carcinoma were taken, including clear cell and serous papillary and undifferentiated carcinoma. Patient with FIGO 2009 surgical stage 1 and 2 of endometrial clear cell or serous carcinoma with positive peritoneal cytology were also taken in this study. So the objective was to evaluate role of concurrent chemo EBRT with chemotherapy versus 6 cycles of only chemotherapy in reducing the rate of recurrence or death. And the secondary endpoints was there an increase in survival with chemoradiotherapy in comparison to only chemotherapy, and then adverse effect and quality of life. So the patient were randomly assigned in 1:1 ratio to the 2 arms. In one, the chemoradiotherapy regimen, EBRT was delivered to the pelvis with or without para-aortic fluid. The total dose was 4500 centigrade in 25 fraction at 1.8 gray per fraction. IMRT and vaginal brachytherapy were only allowed in the chemoradiotherapy group. Along with chemoradiotherapy, cisplatin also given 50 mg per meter square on day 1 and day 29 with volume directed EBRT as discussed, followed by carboplatin and paclitaxel every 3 weeks for 4 cycles. The second arm, the chemotherapy only regimen, consisted of carboplatin of AUC 6 plus paclitaxel at a dose of 175 mg per meter square every 21 days for 6 cycles. Disease assessment was done by serial CT scans and chest radiography as decided initially at the trial. Quality of life assessment was done by FACT-EN tool during the study. So the result came, the mean age in the both chemoradiotherapy and chemotherapy only group was 60 years. 95% of the patients were stage 3. And histology wise, approximately 30% patient in both arms were non-endometrioid histology. So when the recurrence-free survival was seen that there was no difference in chemoradiotherapy and chemotherapy only group, p-value was 0.20. Local recurrence was more in chemotherapy only group than when compared to chemoradiotherapy, but distant recurrence were more in chemoradiotherapy group than when compared to chemotherapy only, and this becomes important because in high risk group there is more chances of distant metastasis. Quality of life at 70 weeks was significantly better in chemotherapy only group. However, neurotoxicity associated quality of life was still better in chemotherapy group. but overall quality of life was better in chemotherapy only. A recent update of GOG 258 was presented in March 23 in the Society of Gynec Oncology annual meeting, showed there was no difference in overall survival among chemoradiotherapy group versus chemotherapy only group. Side effects, hematological side effects were more in chemotherapy group, whereas constitutional symptoms, fatigue, gastrointestinal events were more in chemoradiotherapy group. So to conclude, chemotherapy alone can be offered to high-risk endometrial cancer in adjuvant setting based on results of GOG 258. It offers better quality of life along with better control of distant recurrence. However, local recurrence is more with chemotherapy alone, but we can offer RTI salvage treatment in case of local recurrences later in the line. And grade 3-4 effects were statistically similar in EBRT and chemotherapy. So thank you. That was my presentation. Hello.
So thank you, Dr. Ashutosh, for giving a brief overview of about systemic chemotherapy. So regarding this chemotherapy, I think all of us do agree that there is a role of chemotherapy in high risk setting, say it PORTEC 3 or GOG 258. Only point of contention is that whether we can offer only chemotherapy to any subset of patient or not. So I think last month only GOG 258 latest update was out on the net. Although it was a ESCO post, it may come out in a full paper later on. So it was a final OS analysis of the GOG 258 in which they have said that stage 3 high risk endometrial cancer, there is no difference in overall survival. Although definitely there is a more loco-regional recurrences in chemotherapy arm. But it is slightly higher in chemotherapy arm, but there is no overall survival difference. So at least in stage 3 high risk endometrial cancer, we can consider chemotherapy only without any radiotherapy into consideration. So, but obviously in stage 1 or 2, we can consider radiation. Another difference which I can say that in stage 3, there's 6 cycle of paclitaxel carboplatin, which we need to offer if we are giving only chemotherapy. But if we are giving chemotherapy along with radiation, then only 4 cycle of paclicarbo is sufficient. But another point which I wanted to highlight that if we are coming across serous carcinoma, uterine papillary serous carcinoma, or say clear cell carcinoma, so I think only chemotherapy can be sufficient in stage 3 setting. So that is all highlighted points which I want to
I think only chemotherapy data is still not robust. Until that, we should add radiation to chemo or chemo to radiation until we got more results, more data for that. Until that, definitely we should add chemotherapy in the high risk group patients. Doctor, I have a very peculiar.
Just a minute, Dr. Manoj, just a minute here. So GOG 258, there are 800 patient data, right? And final OS analysis has been out last month only. All of us can go through that. I just want to read one line from that article. For those people who are still skeptical of the role of chemotherapy alone in stage 3, this final outcome of 800 patients should put an end to this question. So 800 data is a robust data, I think. And what we are noticing is serous cell carcinoma.
Let the full paper come. How much that is in serous, how much is in stage 3 with nodal metastasis?
True. Agreed.
Okay. Okay. Now,
so,
madam, can
in a recurrent setting, radiotherapy is not going to benefit that much, the local recurrences. So are we going to make a decision only based on overall survival? What about local recurrences? Because radiotherapy is not going to benefit at that particular point of time when it comes to local recurrences.
Why it is not going to benefit in as a salvage sort of thing?
No, radiotherapy doesn't work that well when it is a local recurrence. Again, the mode of radiotherapy may need to be different also, depending upon what is the bulk of the disease also. So just a plain EBRT with maybe a sorbo will never work. We may have to go in for interstitial brachytherapy. Again, the amount, whether it's going to subside is a very different thing. So that is one point we need to consider. Now I think the standard of practice is something like, sandwich. So whether we're going to move away from a sandwich, yeah, you may say that, vaginal brachytherapy you can omit. That is a valid point. But EBRT, I'm not sure, the data isn't robust, and we definitely need to consider that point, that how well is radiotherapy going to work in the salvage setting.
As Jayalakshmi ma'am said,
I agree with Jayalakshmi madam. I have a very good case regarding to this today. A lady of 58 years old, stage 1A, less than half of the myometrium with the P53 mutation. Now, what should be the ideal treatment for this?
Question to whom? Dr. Manoj?
To you. To you. To the panel.
P53 is mutated, so definitely is a poor risk factor. Right?
Yeah.
And with P53 myometrial invasion, how much is that doesn't matter. So it is less than 50, more than 50. That question is out nowadays. So once P53 is there, so it is high risk. So definitely, I agree in those scenario. Definitely, we have to go for both chemotherapy and radiotherapy as well as per PROTECT 3 data. But what I was saying that,
I have a very clear that if we are going with the NCCN guidelines, in that they have not incorporated the molecular analysis in the treatment arm. Now, if a stage 1A with grade 3, okay, the only vaginal brachytherapy is the treatment of choice in that setting, with no LVSI and no age more than 70 years. If we add chemotherapy concurrent, if we add the chemotherapy, don't you think that it is a over treatment for that? A case in which only vaginal brachytherapy is being offered, and in a case where we are now giving the pelvic radiotherapy with chemotherapy with vaginal brachytherapy and adjuvant 4 cycle of chemotherapy for a stage 1A1.
Can I answer that? मैं Dr. Vinita बोल रही हूँ.
Yeah, why not?
Manoj, either we don't do the test. If we have done the test, then we have to respect.
Yes, we have done the test. That is a P53.
We have done the test, then we have to look at the guideline which incorporates the result based on the availability of the result of this test. So if NCCN does not incorporate it, then we have to look at ESMO guidelines, because NCCN is not incorporating the information of P53. So I agree with Dr. Denny here, although I did not agree with his previous statement. I did not get a chance to speak that in case P53 mutation is present, even if it is early disease, the biology is bad. So this patient will have to be given chemotherapy followed by radiation therapy.
No, madam. It should be the concurrent chemoradiotherapy.
Sir, as per the guidelines, it has to be at least 4 to 6 cycles of.
No, madam, if we are going with the PROTECT trial, then the schedule is the concurrent chemoradiotherapy followed by 4 cycles of chemotherapy. What about Dr. Denny?
ESMO guidelines say that both are equally category 1A evidence. Concurrent chemotherapy followed by 4 cycles of chemotherapy is category 1A evidence. Also, 4 cycles of chemotherapy followed by 6 cycles of chemotherapy followed by radiation.
P53 mutated.
In P53 mutated patients.
P53 mutated, yes. So that is now the PROTECT 4A, that it is concomitant chemotherapy, radiotherapy with 2 cycles and followed by 4 cycles.
Okay. I would like to this to GOG-25A. There are a few flaws as well. As the 4 days back, the update of the GOG-25A came, and the ASCO post has written it. And in that, Dr. Aguila Viswanathan has written the updated toxicity data has still not been published for the GOG-258. And the radiation used in the GOG-258 is the old conventional technique in which the toxicity can be very high, and it can't be matched with the current modern techniques of radiotherapy. And also in the GOG-258, the overall survival, the answer to that, the primary endpoint was overall survival. The study was not powered enough to find out the answer to that. So these are the few flaws of the GOG-258. Maybe because of this, in the NCCN guidelines also, if you look now, we can say it is adjuvant chemotherapy plus minus EBRT. Probably because of the higher locoregional failures in the pelvic and the para-aortic region. And the most common practice in US also, it is sandwich radiotherapy, even after coming, even after results of the GOG 258.
NCCN is quite lagging behind. So maybe in the next, they would incorporate the moleculars also. So shall we go ahead with the...
Right. Yeah.
Yep.
Yeah, shall we go ahead with the last, that is our panel discussion. So I think everything which we are discussing now, probably we can discuss them in the panel as well. So Nishtha is up, she'll be presenting, and mentor Dr. Sapna, she's not well. So Dr. Vinita, she will be mentoring her. And we have Dr. Vinita, maybe you can introduce all your speakers.
Okay. So Dr. Swarupa, now we are starting with this panel discussion, and this panel discussion will be moderated by Dr. Nishtha Sachdeva. Dr. Nishtha Sachdeva is doing DNB in medical oncology, Apollo Hospital. Am I right?
Yes, and she's also radiation oncologist as well.
Okay, she's a radiation oncologist who is pursuing probably medical oncology.
Both. She's a radiation oncologist, now doing medical oncology.
Okay. And her panelists are Dr. Vishal. Dr. Vishal is doing DNB in Gynae Onco from Rajiv Gandhi. Dr. Shreya, DNB Radiology from Apollo Hospital. Dr. Aditi Agarwal, she's a SR in pathology from Gangaram Hospital. Dr. Pravjeet Batla, radiation oncologist from RR Hospital, and Dr. Linthoi. So over to you, Dr. Nishtha. Kindly go ahead and start.
Thank you, ma'am. Are my slides visible?
Not yet. Yeah, now it's visible.
Make it full screen.
So good evening, everyone. I'll be starting with the panel discussion. So a lot has been already discussed, starting from the stage 1, low grade, intermediate grade, and high grade. So
you have half an hour. You have half an hour, Nishtha.
Sorry, ma'am.
You have half an hour.
Yes, ma'am. So I'll be directly starting with the case pertaining to metastatic setting. So before that, I would like to, okay, fine, we'll start. So here is a 63-year-old postmenopausal female with no comorbidities. She presented to us with complaint of postmenopausal bleeding since 1 month. On history, her obstetric history was she was para 2 living 2, last childbirth around 35 years back. All children were normal vaginal delivery. Her age at menarche was 13 years, age at menopause was 53 years, and her BMI was found to be 27 kg per meter square. Now, on examination, per speculum, we could see the bleeding PV was present. Per vaginum, the vaginal mucosa was normal. Cervix was located very high. There was no growth palpable over the cervix. Bilateral furnaces and para was free. Per rectal examination, again, the rectal mucosa was normal. There was no thickening or nodularity felt. Systemic examination was within normal limit. So now I would like to go ahead to my gynae oncology contemporary, Dr. Vishal. What would be the different diagnosis for this case?
Can you hear me?
Hello. Yes.
Yeah. So good evening, everyone. The differential diagnosis of postmenopausal bleeding will be it can be endometrial hyperplasia, atopic endometrium, then endometrial carcinoma, cervical carcinoma, then maybe endometrial or cervical polyp, or maybe sometimes miscellaneous such as trauma. So this can be the differential diagnosis of the postmenopausal bleeding.
Any infective causes that you would like to think about?
Yeah, Mitra can cause.
Maybe genital tuberculosis as well, since
but
TB is a common presentation.
Vaginal discharge rather than bleeding. It will present as a vaginal discharge, maybe foul smelling, rather than for vaginal bleeding.
So just to sum up, it is not only the malignancy we'll think about, we'll rule out the benign and other infective causes as well. So now, Dr. Vishal, what are the further investigations that you would like to do for this patient?
Yeah, when patient is symptomatic, that is post-muscle bleeding, I will like to go ahead with the office endometrial biopsy.
Okay.
In most of the cases, it will if there is a malignancy, endometrial malignancy.
Okay.
So before that, actually, biopsy, the history and physical examination. So already you
Okay.
have mentioned that cervix looks normal,
Okay.
and there is no visible growth on the cervix.
Mhm.
So that in that case, I will like to go office endometrial biopsy with the PIPL biopsy device, and that will give us if there is a malignancy, that will give in most of the cases. If it is
Before
not that,
that,
yeah.
before that, you would like to do any blood investigations or any imaging?
Imaging, yeah, transvaginal ultrasound. So that will
Okay.
give us the endometrial thickness. So
Okay.
in postmenopausal females, 4 mm or less than 4 mm is considered as a cutoff for normal. If it is more than 4 mm, it is considered as abnormal, has to be dealt with biopsy. So which can be at first office endometrial biopsy, and if it is still the diagnosis is uncertain, then one can go ahead with the hysteroscopic biopsy. Hysteroscopic guided dilatation and curettage biopsy.
So these are the NCCN guidelines. They again say in imaging, we have to do the pelvic MRI, then chest imaging, at least chest X-ray. If abnormality is seen, then CT chest. Before that, history physical examination, then CBC, all the blood reports, LFT, KFT. And also to consider FDG metastasis is suspected in selected patients.
Yes, the test will be done when the diagnosis is there, endometrial carcinoma, not with the just post-menopausal bleeding.
Again in the Pan-Asian ESMO guidelines published in 2023 for diagnosis, pathology and molecular biology, they recommend to do with the histological type, FIGO grading, myometrial invasion and LBSI, and molecular classification. Again, for staging and risk assessment, endometrial sampling by biopsy and dilatation and curettage are acceptable initial approaches. And the preoperative workup should include clinical and gynecological examination, transvaginal ultrasound, pelvic MRI, full blood counts, and followed by additional imaging testing. Now, in this patient, the transvaginal ultrasound was done, which shows a heterogeneously thickened endometrium with the loss of fat plane with myometrial invasion. Now, again, MRI pelvis was also done, which showed a large mass in endometrial cavity involving approximately 80% of myometrium with cervical stroma infiltrated. So I would like to go ahead to my radiology colleague, and can you please explain how we are going to see the MRI, or what are the features that can be seen on MRI pelvis in this case? This is not the actual picture. I'm sorry, I could not get the actual picture. So this is a representative MRI pelvis picture.
Good evening, everyone.
Dr. Shreya.
Yeah. Good evening, everyone. So MRI pelvis is the gold standard investigation, imaging investigation, which we can do in endometrial cancer because of the excellent soft tissue delineation, which can be seen through MRI. So we can use a T2 weighted sagittal images in which we can see the prime local involvement of the malignancy, whether when malignancy is involving the less than 50% of the myometrium or more than 50% of the myometrium for staging, and then further the spread of the disease as to cervical stroma, which leads to stage 2 of the disease, and the fornices or the adnexa are also seen in the MRI pelvis investigation, which can lead and also the lymph node staging can be done through MRI pelvis. Any lymph node greater than 10 mm is considered significant, and in pelvic lymph nodes more than 0.8 centimeter are also considered significant. So we can use a dynamic contrast enhanced MRI also sequences in these MRI pelvis, in which we can see the myometrial involvement of the by the cancer. The myometrium will be hyper enhancing as compared to the tumor, and the endometrium, normal endometrium, will be hypo enhancing to the normal tumor. So in MRI pelvis, we can look at all these parameters, and we can then proceed to maybe a FTG PET scan for distant metastasis involving the lymph nodes, in which we can see the distant
metastatic lymph nodes. And also FDG PET scan is mainly an investigation for the determine the response to the chemotherapy. And if the response is good, or if the response is not going good, then we can change the therapeutic plan.
Okay, so the PET CT was done for this lady, which showed an FDG-avid heterogeneously enhancing mass lesion involving the entire endometrium cavity with more than 50% myometrial invasion. Also, we could see some FDG-avid small nodules in right lung upper lobe. Then multi-G FDG-avid bilateral mediastinal and hilar lymph nodes were also seen, suggestive of metastasis. Then this patient, she underwent dilatation and curettage. On the histopathology, it revealed invasive endometrioid adenocarcinoma, grade 1. On IHC, it showed ER/PR was strongly positive and HER2 was negative. HER2/neu was negative. EBUS TVNA was done for mediastinal lymph nodes, which was suggestive of metastatic adenocarcinoma. I would like to go ahead and invite my pathology contemporary to kindly comment on the same and whether any other testing is required to be done in such case.
Yes, ma'am. So this is an invasive endometrioid adenocarcinoma grade 1, which is showing ER/PR positivity and HER2 negativity. So in all these endometrioid carcinomas, we should go ahead with the surrogate IHC to identify the molecular subtype. So we will do IHC for the P53 and for the MMR proteins to identify the molecular subtype. And also we should do the genomic testing or sample sequencing to identify poly mutations. This will have important prognostic and therapeutic implications. So it is important to identify the molecular subtype.
So this is the NCCN guidelines, and these molecular genetics has already been dealt in detail. So I'll be skipping this. Now coming on to Dr. Vishal again, how are you further going to treat this patient?
Can I interrupt you here? I'm Dr. Vinita Goyal this side.
Yes, ma'am.
Somehow is this case real? Because
yes,
things seem to be not fitting so well. I mean, on one hand, we are saying that it is a grade 1 tumor, ER/PR is positive. On the other hand, we are saying that she has a mass confined in the endometrium. There are no pelvic and para-aortic nodes, and directly there are mediastinal nodes.
Yes, ma'am. This patient is currently being treated in Apollo. Actually, I have met the patient now during this time. The initial part, this all has been taken, the history has been taken from the patient only, ma'am.
Okay. So I'm sure it must be a correct diagnosis and treatment, but I would still urge that we always have to use our clinical understanding, in treating a patient.
Okay, ma'am.
The PET scan description that you gave was suggested, would it not show any pelvic and para-aortic nodes? And
Yes,
directly there are mediastinal and hilar lymph nodes. Hilar lymph nodes we always take with a pinch of salt, especially in a tropical country like ours. And
yes,
lung
ma'am.
is only a solitary nodule. So I would say that, all of us should question sometimes the PET findings also when we are seeing such a situation. However, you may proceed. I agree that if you are presenting, then the findings must be absolutely correct and verified. Please go ahead.
Thank you. Now, Dr. Vishal, how would you like to treat this patient?
As this is a metastatic adenocarcinoma with positive lung findings also, I would like to refer for systemic therapy, that is chemotherapy first.
Okay, and what about my radiation contemporary? How would you like to go ahead? Any role of radiation at present for this patient?
Not at present, ma'am. In a metastatic state, it is better to treat her with systemic therapy upfront with the paclitaxel and carboplatin.
Okay, so the plan should be systemic therapy, and as it is shown even in the NCCN guidelines, if it is a suspected extrauterine disease, then whether it is suitable or it is not suitable for primary surgery, we have to go ahead in cases of distant metastasis with systemic therapy plus minus EBRT plus minus SBRT or THPSO, depending on the condition. Now, Dr. Linthoi, how would you like to proceed with this patient? Dr. Linthoi?
I audible?
Yes, yes.
Okay. So these patients, we need to know the MSI status, that whether the patient is this MMR high or MMR deficient. If it is MMR deficient, the latest trial conducted means like the NRG GY018 trial. In this trial, they have given upfront pembrolizumab combined with carboplatin and paclitaxel, and they have found that the 1-year progression-free survival was significantly improved with the addition of pembrolizumab to this carboplatin and paclitaxel. So, if the patient is able to afford, then I would like to recommend the combination of immunotherapy with this one chemotherapy for her treatment.
Patient is her MMR is proficient. She's
Proficient. Okay. In that case, then I will then I'll give combination of carboplatin and paclitaxel for 6 cycles.
Nishta,
Yes, ma'am.
Did you do the molecular?
Ma'am, MMR was proficient. That is what I could. Only IHC for MMR was done.
Only the MMR was done.
Yes, ma'am.
The other markers were not done?
No, ma'am.
Okay.
As Vinita ma'am have said, probably this patient is P53 mutant. Probably that's the reason why the disease has gone from uterus directly to the lung.
I think these are the patients in the moleculars should be done.
Yes,
when
ma'am.
it's such an unexpected presentation. So the moleculars are very, very important in these cases. Yeah, go ahead.
So the first line therapy or the preferred therapy is systemic therapy with the paclitaxel carboplatin based chemotherapy for minimum of 6 cycles. Even the ESMO guidelines, if we go ahead, in these cases, paclicarbo becomes the standard of care. And in this patient, she was planned and started on chemotherapy with paclitaxel and carboplatin. PET-CT reassessment, PET-CT was done post 3 cycles, which showed partial response in the primary disease. And even in the lung and distant metastasis, we could see some regression. Patient finished 6 cycles of chemotherapy. However, post finishing the 6 cycles of chemotherapy, patient went to her hometown. There she got a PET-CT done, which was suggestive of disease progression, both on the primary as well as in the distant metastasis. Dr. Lintoy, how to proceed further? Dr. Lintoy?
Nishta, ask someone else.
Sure, ma'am. Dr. Vishal? Dr. Pravjeet? Anyone? It's an open question now.
We'll assess we'll do a reassessment of the disease after the 6th cycle of paclitaxel and carboplatin. And on the reassessment, we need to see whether the patient is responding, has responded to the therapy, or whether it's a partial response or a progressive disease. In case if it is not responding to the primary therapy, we might have to change it to second line chemotherapy, in which then along with either it can be re-challenged with a platinum drug, or either it can be taken up, the patient can be taken up for immunotherapy with pembrolizumab, depending upon her MMR status.
So for this patient, she was then started on single agent injection lipodox, which is liposomal doxorubicin for 4 weekly. Post 2 cycles, actually she came to us after receiving 1 cycle of lipodox at her hometown. So then we gave the second cycle here, and after which she developed massive PV bleeding. And for this, she received 20 gray 5 fraction of hemostatic RT. Post the bleeding was controlled. Then she also had certain reactions with lipodox. So the treatment plan was changed to injection pembrolizumab plus tablet lenvatinib based chemotherapy, which was given every 3 weekly. The trial for this I'll be going to show at the end. So after 6 cycles of pembrolizumab plus tablet lenvatinib, she had good partial response on both primary disease as well as distant sites.
And at present, she has finished eight cycles till now. And we plan to continue this patient on pembro plus lenvatinib till progression or till maximum of 35 cycles, as has been mentioned in the Keynote 755 trial. So this is the trial Keynote 755, which has been published in NEJM in 2023.
Just hold on. When you're talking about all these therapies, when you're talking about pembrolizumab, if you're mentioning how many cycles are done, how is the response? It is essential that you mention about the toxicities also.
Ma'am, she is tolerating the pembrolizumab and lenvatinib fairly well.
This is not the correct answer, beta. The correct answer has to be, you have to talk about hematological toxicities, fatigue, anything, you know, in a correct fashion, and mentioning what was the grade of toxicity. I mean,
her fatigue was grade 1, and the blood counts, even the myelosuppression, the neutropenia and thrombocytopenia were again grade 1, ma'am. She did not have that, all the toxicities were grade 1, ma'am.
So the purpose of these seminars is not only so that all of us should read and understand the literature, but you also have to understand how to present it also and how to evaluate a patient also. The evaluation is never in terms of only the response on the PET scan.
Yeah.
Yes?
Yes, ma'am.
Yes. Okay, please proceed.
So this is the trial, the Keynote 755 trial, in which it was a phase 3 trial in which the patients were randomized to either the patients who had already received at least one platinum-based chemotherapy regimen were randomized to either lenvatinib 20 mg administered orally once daily, plus pembrolizumab 200 mg IV 3 weekly, or chemotherapy of treating physician's choice, which could be either doxorubicin or paclitaxel. In this, they had seen around out of 827 patients, 697 patients had proficient MMR disease and 130 patients had mismatch repair deficiency. In terms of the progression free survival.
Go back to your previous slide. Can I read a line from this? In the results, if you go to the last line, it says that adverse events of grade 3 or higher occurred in 88.9% of the patients who received lenvatinib plus pembrolizumab, and in 72.7% of those who received chemotherapy. So maybe it is not possible that, you know, the side
I mean, these patients have received maximum up to 35 cycles. She is still in the early phases.
Okay.
Shall I go ahead, ma'am?
Go ahead.
Shall I go ahead with the slides?
Yeah.
So in terms of in terms of the progression-free survival, we could see that the lenvatinib plus pembrolizumab arm showed better progression-free survival of 6.6 months versus 3.8 months against the chemotherapy arm in both the patients who were overall population as well as in the proficient MMR population as well. Similar was with the overall survival. It was better in the lenvatinib plus pembrolizumab arm in all patients as well as in the proficient MMR population. This is important because generally when we add pembrolizumab or dostarlimab or the immunotherapy which we consider, generally are preferred in the deficient MMR population or the MSI population or the patients with high tumor mutation burden. So since the majority of patients in this population are proficient MMR population, so to target that, they have incorporated, and based on this trial, lenvatinib and pembrolizumab has now become standard of care for the patients who are proficient MMR. And even in terms of toxicity, the grade 3 toxicities or the adverse events which were more in lenvatinib plus pembrolizumab arm were hypertension, which was managed based on medical management. And in the chemotherapy arm, the neutropenia and the thrombocytopenia, the myelosuppression was more as compared to the lenva plus pembrolizumab arm. So to conclude, this patient, she presented with metastatic endometrioid adenocarcinoma. For these patients, the molecular testing should and must be done. The standard of care in proficient cases becomes the systemic therapy, which is the paclitaxel carboplatin-based chemotherapy. For this patient, in view of the widespread distant metastasis, upfront local treatment was not and could not be given. Moreover, patient had aggressive disease since she progressed immediately after first-line chemotherapy, which further contributes to poor prognosis in her case. As in all these trials, the median overall survival with chemotherapy is found to be around 1 year. Further treatment with pembrolizumab plus lenvatinib has shown to improve both progression-free survival as well as overall survival in these cases.
Dr. Nishta, if a patient is not affording for lenvatinib and pembrolizumab, then what would be the second-line chemotherapy?
Sir, in that cases, we'll go ahead with if it is a proficient MMR case, then we have to go ahead with the single agent regimens. It can be any one of the physician's choice, like liposomal doxorubicin, paclitaxel. It will again depend on the patient profile, the tolerability of patient performance status, and comorbidities.
Nishta, retrospectively, looking at the case, this is very different, not as we would have expected this patient
Yes,
to
ma'am.
be. Anything you think which could have been done, any other tests which you would have recommended, or any difference in your treatment, in your approach to the patient, do you think?
Ma'am, to begin with, I would have liked that the IHC, the molecular complete panel should have been done for this patient. Because that will also we will be able to prognosticate, and maybe as you all have correctly said, had the patient's profile suits more into the P53 mutant type, since she's presenting very atypically. But therapeutic wise, P53 as of now in metastatic setting is not going to change the directed therapy.
Yeah.
Other options such as anti-RK gene fusion positivity, larotrectinib is there, but it is again category 2B.
Could it have been something other than the endometrioid carcinoma?
Yes, ma'am. The other other high-risk pathologies should have been evaluated, but to begin with, it came out to be endometrioid adenocarcinoma.
A word regarding, just not the therapies, even in the workup. I think it should be incorporated when you are, Nishta, when you are presenting also, and it has to be recorded also about the BMI, about the infertility status, and particularly in this era where we are legally liable everywhere, these small points are going to be very helpful whenever something comes up in your practice, whether these have been recorded or not. Unopposed estrogen, exposure. These things have to be recorded in a positive or a negative way. Family history of CRCs, they have to be recorded, even at presentation.
Yes, ma'am.
I also wanted to highlight that this patient had a ERPR positive tumor.
Yes,
exactly. Could be P53WT.
Yeah, I mean, sometimes even if, you can even think of putting these patients on maintenance hormonal therapy.
Absolutely, yeah.
That should not be forgotten.
Yes, ma'am. Ma'am, putting these patients on hormonal therapy is an option. Is definitely an option, but it goes more with the patients who present with very low-grade indolent disease. She has a very aggressive kind of disease because post first-line chemotherapy, she progressed immediately.
But even in that category, P53, wild type, whatever, even in that you have these subcategories, right? They are coming up with these, L1 CAM and others which have a much more aggressive phenomenon within that subcategory. So,
yes, ma'am.
I'm sorry to say, but your presentation was a bit incomplete. If you were talking about all this, then you should have shown some pictures of PET scan to convince the audience of what you were talking about. Right?
Ma'am, I actually had shown.
Yeah. So the mets in this are not very clearly visible, except for the medial cell and lymph nodes. The lung mets are not very clearly visible. They are not very convincing. Yeah.
Yes, ma'am.
So, I mean, and P53 was not done. We are all assuming that this must be P53 mutated.
Ma'am, it was not done in this case.
Yes,
Only
yes,
MMR.
no problem. No problem. I mean, these cases are for all of us to learn.
Yeah, exactly.
Anyway, a very good discussion. Anything else that you want to ask your colleagues?
Just closing remarks, nothing else.
Okay. So I think we hand over the stage to Dr. Swarupa and Dr. David to take it to close the session now.
I think the whole session was worthwhile. And
Yes.
I hope it really helped us and all our residents. And all the residents, they had worked very hard and within a very short schedule. And all of you have done very well. But like Dr. Vinita said, it is not only presenting, it is the right way of presenting. And because this is the time which you learn, and later on, nobody's going to tell you what was right and what was wrong. So this is actually the time you should know, and you should actually work hard in the way it is presenting. Like, the same thing, your presentation this time, it does show that you could have probably worked a little more harder. So those kinds of things. So whatever you do, it should be with your full involvement. But otherwise, everything was very nice. And Dr. Vinita, thank you so much for giving me this
Dr.
opportunity
Swarupa.
to moderate this. And it is a great idea you had that is a presentation. This is a session for the DNBs, for the residents and by the residents. And I'm sure this is going to carry on further. So I thank everyone. Nidhi, thank you so much for always being there. And all the faculty, all the mentors, and all the residents. So everyone, thanks a lot. And this was a great, the maximum number we had was 135 participants. So that means, how important this topic is and how much we want to know about this topic, endometrial carcinoma. So much. Thanks a lot, everyone, and wishing everyone a good night.
Thank you. Good night to all of you.
Thank you, ma'am.
Good night. Thank you, ma'am. Good night.
Thank you, ma'am.
Thank you, everyone.